Hi guys, just make sure you sign in. There's a QR code in the front. You can just scan it with your computer with your phone's camera, and the link should pop up. If you guys are having trouble, let me know and I'll help you guys. I'm just gonna get started in a little bit. I'm gonna wait for a little bit more for any like latecomers, and then we're gonna get started. All right, I hope everyone signed in. It doesn't seem like anyone else is coming, so I'm just gonna start. Can that's strange. Can you hear me?
Yes, we can hear you.
Awesome. Okay, I don't know. Wait, I think it's because. Okay, I fixed it. Cool. Oh, I'm so sorry. I had work earlier today and we're on Zoom, so I ended up putting like the Disneyland background. So I'm just gonna keep the Disneyland background. Just letting you guys know that this is being recorded, so anything you say or ask will be shown to everyone on YouTube who watches this or everyone like the house coordinators. So I'm gonna introduce myself. Hi, I'm Sophia. Sophia, go away both. I'm currently an OB, so I took mental health 2 terms ago, but I was the mental health tutor last term. So for PAL, so this is still pretty fresh. Um, I'm pretty sure you've heard it from everyone. Yes, mental health is a very big and failed class, but I passed. So if I feel like if I pass, everyone else can pass, okay? Um, so I know it's scary, and I know there may have been a possibility that your first quiz may have not been so hot, and that's the question I was waiting for. So here's the thing with me personally, and you can go by my views or not, but I personally will not tell you who I had because I feel like it deters people from coming to PALS. And I'm not gonna lie, like I was the same. I was like, okay, I don't want my PALS tutor. I don't want to be in my PALS session if my PALS tutor didn't have my teacher. Um, but I've been into PAL sessions that from people who have from far away that have not been my professor either, and I've scored really high grades on their exams too because every PAL tutor um, has had their own studying, has had their own knowledge. So I'll tell you guys who I had at the end, but personally, to start off with, I feel like it deters people from coming, so I'd just rather not say. Not trying to put down anyone else. I just feel like information is information and nursing is nursing as it is. So what you're gonna learn from one professor is going to be maybe slightly different than the other, but there's I personally don't think there's any difference. Yeah, so I feel like the more information you're gonna get is amazing because at the end of the day, you have that proctored, and no matter what, that proctored, no one has seen that proctored. Your professors haven't seen that proctored. So the more information you get from more people, from more perspectives, the better chance you have to get a higher grade on that proctored. I got a level 3. All my students from last term got a level 2 or 3. So I'm doing something right if they're passing, okay? So yeah. Um, so how was your first quiz? How was your first quiz? I know the founders and the hypotheses. Yeah, yeah, me too. Don't worry, me too. I didn't score so hot on my first one either, but there is hope. There is hope right here because I did never thought I was gonna be in this position. And I did have a really like harder teacher, but I think mental health's just hard because it is a disciplinary. So it's not like med surge where it's like black and white. Like it's like, ooh, there's a lot. Meds are gonna scare you. I have a thing for that to help you guys. So hopefully it makes it easier on you. Here's my thing with my meds. Listen from me now, and I'm pretty sure your professors have said it. No one wants to take me seriously, but please know your generic names. Know your generic names. Know your generic names. In this PALS tutoring, I don't know about other PALS tutors, but at least in mine, we're gonna know generic name only, and we're gonna speak generic name only. Keep it as you guys should have been starting back in funds knowing generic names, but because everyone loves their brand names, generic names kind of get thrown in the back. But you will thank me, and my students last term thanked me that when it came down to their proctored, all they knew was the generic names, so the meds were like so easy for them to know. So that's my biggest piece of advice. Yeah, generic names are better. I feel like more educated. Like when people are like, "Oh, I take albuterol," I'm just like, I just feel like so much more like intelligent when I give them a generic name. Okay, so yes, that was me. My biggest piece of advice is know your generic names. Starting from, should have been starting from friends. Like I repeat. I'm just really weird. Okay, I'm sorry. Yeah. So when you go into intermediate, there's gonna be a lot of meds. They don't end. Those meds will not end. They will haunt you forever and ever. Know your meds, know your meds, know your meds, know the generic name of your meds. Okay. Here's the thing, because at the end in preceptorship, yeah, you have your med surge proctored, but you also have your farm proctored too. And there's a reason that they don't give you your farm proctored in pharmacology, because you don't know anything. So they give it to you during preceptorship. And guess what? They don't give you Miralax. They don't give you Tylenol. They give you acetaminophen on your test. So start the habit now of knowing that generic name. Okay, if I were you, that would be my biggest, strongest piece of advice. So let's start. Let's get started. Do you guys want? So here's some things I use that I found that helped me be successful in this class and helped me achieve my A. I found that the MedSearch Success book, the second edition, really helped. No, not second. I'm sorry. The third edition is purple and orange. I'm so sorry. It's the third edition. That one helped me a lot. Professors like to use those questions as a guide, as those are very NCLEX type questions. Mine, yeah, I'm sorry. Yeah, I got McDonald's Wi-Fi over here. Sorry about that. But
Hi, sorry for being late.
you're good. So yeah.
I'm sorry, you said the med
Uh,
surge book. Which one?
The third edition, the MedSearch Success. Not MedSearch. I'm sorry, Mental Health Success book. Let me see if I can pull it up for you guys. It's purple and orange. So, what professors do you guys have, so I can get an idea of who you guys have? You guys can type it in the chat.
Is it this one?
Is that the purple one? Yeah, that one. That one's amazing. Yeah, it's this one. Ooh. Ah. Can you see it? You guys saw it.
Yes,
It's a
I can see it. Thank you.
purple and orange cover. Professors like to use those as guides, and sometimes I'm not saying that there is. Don't take my word for it, but there might be a question or two that might be very similar, and you might see it. So you know that it's better safe than sorry. Plus, that really helped me for the proctor. Yeah. So know your generic meds. How many of you guys have Middleburg? Do I have Middleburg students here? How about 10? 10 students. Who's that other one? Wallace? Is Wallace teaching? Middleburg? He's awesome. I heard he's really fun. He gets really close with his students. He starts giving out his personal phone number. Like I had a preceptor back when I was in med-surg, and she's like, "Oh yeah, we were texting the other day." I was like, "What?" Yeah. So get really close with him. Wallace isn't teaching. Oh, so is it? Okay, so I know it's 10 for sure. Middleburg, and is it who's the last one? James Maras. It's those three. I think it's those three then. All right. Okay then. Okay, cool. Yeah. If you guys keep coming, trust me. I was like, if my students were able to get them last term, then you guys can for sure. Okay. So you guys are learning about. Let me see what I have here. Schizophrenia.
Yes.
Okay. Give me questions. What do you guys want to learn more about? Because I can go on and on and on about schizophrenia, but I want to know what you guys need to be focused on. And it's okay. We got 2 hours of this. If you got a specific thing you want to know about, then we can totally talk about that.
Oh, yes. Positive and negatives.
Okay, cool. Let me write that down.
So what I'm a little confused about, just to let you know, Sophia, is on the positive and the negatives. Like I'm just confused. Like when they say positive, does that mean, oh, you know what? I'm gonna let you do your thing. Sorry.
You're okay. You're okay. Don't worry. Okay, so positive, negative symptoms, drugs, of course. Um, yeah, positive and negative symptoms. It's because we're used to like positive being something good and then negative being something bad. So think of it in this case, positive, negative symptoms like mathematics. So positive, you adding. Negative, you're subtracting. So positive symptoms in a schizophrenia patient would be something that's added on to something that's added from a normal patient. Oh my God, this is dissing that thing. I'm so sorry. I'm gonna remove it because I can't do this. So um take it as in like positive symptoms are something. So you have your normal human being. It wouldn't be us because we're nursing students and that's a whole different type of dragon or monster. So think of it as a normal human being. You have your regular moods. They eat every day. They go to have a 9 to 5. Like they go to school. Just a regular human being. And then you have on this side, would this be like positive or negative? I don't know. So this is my positive. So it's everything that's added on to a normal human being. And then everything that's negative is everything that's taken away from that normal human being. So, for example, do normal human beings hallucinate? If we're not on drugs, if we're not on this, if we're not,
No,
do we
no,
hallucinate? So would hallucinations be something you're taking away from a normal human being, or would hallucinations be something you're adding on to a normal human being?
adding.
Adding. So if you're adding something onto this normal human being, what is it?
Positive symptom.
Positive symptom. So that's how I kind of know it. It's hard. It's a weird concept. I understand, but just think that's the most simple, basic way I can put it. Positive is anything that's added on. Negative is anything that's taken off. Energia. Normal human beings have energy, but when you're taking away that energy, energia, you have less energy. You're taking it away. So what is that?
Negative.
Negative. Okay. Um. So let me see what I can give you guys. So hallucinations, alterations in speech, and concrete thinking. So concrete thinking is kind of confusing. Those are all positive symptoms that you're going to see in schizophrenic patients. So concrete thinking is the inability to think abstractly. So you know how we can imagine, we can come up with events that have never happened in our heads, kind of like that. We're thinking outside the box. So that's the ability to take that, the ability to not have that portion is a positive symptom of concrete thinking. So that's the only one that might be a little confusing because it's just like, oh, well, you're taking away our ability to think.
Can you repeat that, please? Sorry.
So yeah, so concrete thinking is the inability. So hold up. Before I start, my parents are here, my brother is here. I'm gonna apologize beforehand, okay? Because I live in a Mexican household and there's no rules here as much as you want them to be. Okay, so concrete thinking is the inability to think abstractly. So like humans, we are imagining, we're exploring in our heads, we're thinking outside of the box, we create situations that aren't real. That's abstract thinking. In concrete thinking, you're taking that away. So you can be like, oh well, this is a pen, but it's also a rocket ship, and they're like, no, that's a pen. Like, what are you talking about? Like, oh, but it's a rocket ship. No, it's a pen. That's concrete thinking. So you're taking that imagination away. You would think that one's kind of like your imbalance. You're taking away the imagination, but it's not a negative symptom. It's a positive symptom because you're adding on the fact that they're not able to think abstractly. Alterations in speech. There's so many alterations in speech that I'll just go over that. And then delusions are false fixed beliefs. So like, I believe that I'm God, or I believe that I am Wonder Woman. So that's a delusion. Like you think that it's a fact that you are God, that you as in like the schizophrenic patient, that they are 100%, that they believe that they're a certain thing. That false fixed belief. So no matter what information you can give them, they continue to believe it and falsify. Oh, sorry. Yeah, my mind goes at like 1,000 miles an hour, so sorry about that. Yeah, tell me to go slower. I'll go slower for you guys. Okay, so the 3 positive symptoms are your hallucinations, your delusion, so the false fixed beliefs, your alterations in speech, which we're gonna go over, and then your concrete thinking. So one big thing that happens with schizophrenic patients is their auditory hallucinations. So when they're auditory hallucinations, you always they can start giving them ideas of like self-harm or harming others. So you want to always ask them like, oh, so like what are the voices in your head telling you? Yeah, it's something you don't want to like it's kind of like in between, like, yes, you don't want to like push forward like, oh yeah, of course they're real, but you want to know what they're thinking. You want to know because there's something that you can't hear. So what about they're telling them like, oh, um, go kill yourself? That's putting the patient in harm's danger. So that's one thing as a nurse that you have to do is continuously ask them like, oh, so like what are they saying? Like dive deeper into those auditory hallucinations because those can be a big risk factor in danger.
So if you do that, is it also like you're trying to validate how they feel in a sense, or also like therapeutic communication? So like you don't want to
So
make
yeah,
sure.
that is in between therapeutic communication and safety.
Okay.
Yeah, there's a really big thing that you're gonna see a lot, and that I saw in my proctor is a lot of therapeutic communications. So yeah, it's they're not gonna ask you specifically like, oh, like what is this trying to validate? It's gonna be like, oh, your patient is undergoing auditory hallucinations. As a nurse, like what should you do? You would ask them a question. The first thing that you would ask them is, what are they telling you? Like what are the noises telling you to do? Okay, so alterations in speech. So these are, they appear in speech, but they're a type of thought process, okay? So when you see these in a patient, they are indicative of an altered thought process, okay? So you have, okay, so you have 4 different types of alterations in speech. So remember, these are thought processes that come out in speech. So you have, and these are still positive symptoms. So associative looseness, so that's just a jumble of words. It's called word salad. It's very, very extreme, and they're just all over the place. Dog, cat, bat, well, that's like more echolalia. Like the rhyming words. So like just random words. Book, like it's just a jumble of like, sometimes they're not even like words that mean anything. It's just random words all over the place. And when it gets to that point, then you know that their schizophrenia is very, very severe. And then you have neologisms. So neologisms, neo means new. So they're new words that mean nothing to the regular human being, but their meaning is only towards the patient. So like, and I can be like, this is a jibble jabberish, and I will say that I want my jibble jabberish, but you're just like, the nurse is like, what is that? And you're like, well, my jibble jabberish, and then the patient points at the pencil. You're like, oh, so this is what it is. This is a pencil. This is a pencil, okay? So that's a neologism. Echolalia is the pathological repetition of another's words. So it's kind of like mimicking. So like, let's say the dog is cute, that would be coming from me, and then the schizophrenic would be like, schizophrenic patient would be like, the dog is cute, and would repeat every single word I've said starting from there. So that's echolalia. 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 Oh no, you're good. Don't worry. Don't worry. Don't worry. You're okay. And then you have clang associations. So those are groupings of words, usually rhyming words that are based on similar sounding sounds, even though the words themselves don't have any logical reason for them to be grouped together. So those are just rhyming words. So rhyme, I have here like an example would be wrong song gadong. They don't make any sense and they shouldn't be together, but they are together because they make sense to the patient. So their clang associations are just based on similar sounding words. So those are your alterations in speech, your associative looseness, your neologisms, echolalia, and clang associations. And then these are also other speech patterns that you might see. So remember their thought process that come out in their speech. And they are always indicative of altered thought processes. So if you see these, just know that their thought process is altered, okay? So circumstantiability, it's kind of like they're telling a story and they start off at like point A and it's like my dad ate some beans today, and then beans grow on the farm, and then the farm is really far, and then you know what else is far? Europe, and then Europe is in the other side of the world, and then wait, beans. My dad ate beans yesterday. So see how that story kind of just started from one point and then kind of just went off to like who knows where, but then it ended up coming back to the same point. So that's circumstantiality. So think of like going in a circle. Like a circle has a circle circumference. So it's like they both start with C's. So circumstantiality, they start at one point in the story and they go off, but they come back to the point. Okay. So and then you have tangiality. So these are patients that tell a story, but just keep going on and on and on in a tangent. Okay. For example, my dad ate some beans yesterday, and then beans grow on the farm, and and they just keep going and they keep going, but they never get back to the point. Kind of like if you're talking to like a kid, like a first grader, like when they talk about who knows what, and they just never get back to the point when they were talking about cookies, and now they're at like cars and stuff. So it just doesn't make sense. It's just going off on a tangent. So flight of ideas. So it's just these are rapid ideas that come from one to another. So it's just
I'm sorry, I didn't get the name of that one. Which is the one you're talking about? Flight. Okay, thank you.
Flights of ideas. So it's just moving rapidly from one idea to the next, the next, the next, the next. Sometimes it gets too fast that it's hard to understand them in conversations. So these people are like kind of like me, but way faster. So their mind and their words are just going one after the other after the other. Okay. And then pressured speech. So urgent or intense and resist comments from others. I don't think I ever saw this one. So just know that this is urgent or intense and resist comments from others. Another another positive symptom that you're going to see in schizophrenic patients is magical thinking. So this is believing that thoughts or actions affect others' consequences. So this is like if I move this, then this is gonna happen to that person. You know, so believing that everything that you do causes an effect on the other person. So that's magical thinking. And then paranoia is also another.
Hold on, Sophie. I'm sorry to cut you off. So I'm not clear on magical thinking. Like, can you elaborate a little bit more on that?
Yeah, let me get into that. Let me see. What else I have?
Because what I have for magical thinking is that it needs to have a goal setting, it needs to look into the future, it needs to have a problem resolved, and the difference. So an example that I thought that the professor gave in class was if there's a patient and he's having problems with like with your dad, right? And you don't want to talk about your dad anymore. I mean, you're trying to avoid talking about your dad because whatever, your dad left, so you're trying to avoid that. So then the goal, the miracle would be for the one that's giving the interview is for that person to get Eric to talk about the dad, to express his feelings about the dads. And then by doing that, you would ask the patient to look into the future and say, so what would the future look like if you had a good relationship with your dad? But I just still don't quite get it. I don't know if I'm doing this right.
No, you're good. You're good. I do remember that one. That's another thing. I do remember that one, but it does tie into magical thinking. I do remember that one. It's because that, from what I have understood, that's what the nurse is doing, right? In your example, that's like what the nurse is doing in their half, like trying to get them to think that way. The magical thinking in this case is something that the patient is doing themselves. Let me see. I'm trying to find it. If not, I'll look through my other notes.
Oh, wait a minute. So I was confused, Sophie. I was confused because I was thinking about the miracle question and you're talking about the magical
thinking.
right?
Yes, miracle.
Okay, sorry.
Yes,
So
that's
yeah,
okay. So yeah, that's gonna get kind of confusing
okay.
with them. So yeah, so you are right on that. Yes, miracle question is the one that's like, oh, so that's kind of thinking into the future, while magical thinking is something else. But let me get magical thinking because I felt like I did like a terrible job on that. Let me see. So yeah, that's the miracle question. I do remember that though. That's something that you always want to do for every patient, no matter what type of no matter what type of neurocognitive disorder that they have. Those are really good to always ask because it's always good to be optimistic towards the future. Okay, here. Yeah, so I have here used to envision future when problem is not present, used to establish goals. What would it look like if? How might it be if? So that's for the miracle question. Okay, I guess I didn't write anything down for magical thinking, but like magical thinking, from what it says here, from what I have here, it's just, where is it? I think I lost it. Pretty sure. Yeah, so they're just a distortion of thought process and believing that thoughts or actions affect others' consequences. That's what I have here. So like, oh, me doing this causes this to happen to that person. Give me 1 second. Sorry about that. Paranoia is, so magical thinking is another positive positive symptom that you will see with schizophrenic patients. Paranoia as well. I'm pretty sure we know what paranoia. So you guys, I'm sorry. Okay, so alterations in deep in perception. So you have depersonalization, derealization, hallucinations, and illusions. So depersonalization, so the person themselves is altered, so that they feel that they have lost their identity, that they don't feel that they don't belong in their body. So that they feel like their hand doesn't belong to them or their leg doesn't belong to them. So it's just a feeling that you don't belong in your body. derealization is the feeling that the environment is altered. So something is happening in the place that you're at that you don't feel that you belong there. So depersonalization, something's happening with the person themselves. Derealization, something's happening with the environment. Hallucinations, they affect all their senses. So you have auditory, visual, olfactory, gustatory, tactile, and command. So the most dangerous ones to always watch out for are auditory and command. So auditory, as a nurse, as a nursing action, you would, like I explained earlier, do you hear people talking to you in a room alone? And then command, hallucinations are the hallucinations, and they can be anything from visual to auditory. They're usually auditory, and they're telling the person or they're telling the patient to do a certain action. And those are number one on your list if you end up seeing that your patient is having these, because they also can place a patient at risk for harm, or the people around the patient at risk for harm. And then visual hallucinations, they're less common than auditory, but those ended up being like, the visual hallucinations end up being like delusions. So you're going to see vision, what am I forgetting of the word? Like alterations in like vision and shapes, okay? Sorry. Catatonia, so pronounced increase or decrease in the rate of movements. So these patients will just stay there and they won't move, and you're not going to know how they don't get up, they don't blink, they don't do anything, they don't get up to go to the restroom, nothing. They're just catatonic, like a statue, just there. No moving, or they look like they're slow or stuck. Then you have motor retardation, so that's the slowlessness in motor movement. So they just start to become, their movements start to go slower. As we go like this, they may take like a longer time to get to their goal through movements. And then waxy flexibility is something you're going to see very, very often. So this is when like the nurse raises their arm and they just stay there, kind of like a wax statue or like a Barbie doll. So you just like raise their arm and they just stick there, or like you place them in a certain position and they just stay there. But that involves someone doing something to the patient and having their limb or whatever they're doing, their mouth, their eye, to stay at that. So that's another thing you're going to see with patients with schizophrenia. Remember, these are still all positive symptoms, okay? We haven't hit negative symptoms yet. And then echo, so kind of like echolalia, where you're repeating the person's words. There's something else called echopraxia. So this is repeating or mimicking the other person's movements. Kind of like those mimes. Is that, no, not a mime. I'm thinking something else. But like kind of like a mirror image. Like you go like this, and they go like this, like two, and they go like this, and then they go like this. Echopraxia, mimicking of movements. Impaired impulse control is very big, so they can't control their impulses. So as a nursing intervention to do with these type of patients is to make boundaries very, very clear. So they're interrupting and they're throwing food on the floor, and this can escalate. It kind of you're gonna kind of see this in patients with ADHD, which is something that we're gonna talk about later on. Gesturing and posturing, so assuming unusual or illogical expressions such as grimace, so that unusual or illogical expressions. So like this, I would say you're gonna see these like patients laughing during a funeral kind of thing. Patients laughing during a funeral. You're gonna also see this with bipolar maniacs as well. And then boundary impairment, so they don't know what's a bubble. They're gonna go into your bubble, and this is standing too close, or drinking out of a person's cup, so they don't know what boundaries are. And it doesn't just happen in psychosis. You're gonna see this in many other many other kind of impairments. So negative symptoms, we're on negative symptoms now. So remember, this is everything that you're taking away from the normal patient. So everything we just previously talked about, that's everything you're putting onto the normal patient. So that's your positive symptoms. The negative symptoms is everything that you're taking away from the patient. So these start to appear before positive symptoms. That's something you're gonna see. So you have your 5, 6 A's, 5, 6 A's. I knew it as 5, but I guess there's 6 now. So you have your anhedonia. So that's reduced ability or inability to experience pleasure. So this can be included in depression, but it's not depression. Okay, but it doesn't mean that there's depression. They just um, don't want to do things in life anymore because like going on a roller coaster makes people fun if you like going on roller coasters. Well, they don't find going on roller coasters to be fun. They'll just have a flat affect, and so a flat affect means that you're not showing any emotion at all. um, and they just don't find happiness in life again. But it doesn't mean that they're depressed, or doesn't having anhedonia doesn't mean that you have depression. But patients with depression tend to have anhedonia. Okay. And then you have avolition. So this is a loss of motivation. So these patients can like have no motivation, or their motivation is so small that they don't have a motivation to just get up and go on with their day. They'll just be flat in their bed, or they're not motivated to do any activities. So one trick that I found that works for me to know this specific negative symptom is that in abolition there's a V, and so there's a V in motivation as well. So I'm like, okay, abolition, there's a V, motivation, there's a V. Loss of motivation, abolition. Okay. Um, Negative symptoms, more negative symptoms. So asociality, just like the word says, that they're not social, that their social life has decreased. They don't find themselves being as social as they were in the past. Affective blunting. So that's constricted or reduced affect. So kind of like what I said, that you're not going to see you're not going to see their expressions being outward as much as you would expect them to be. Let me turn on the light. Apathy. So this is a decreased interest in, attention to, or activities or beliefs that would otherwise be interesting or important. Apathy. So it's kind of different than abolition. Abolition is the motivation, compared to apathy is just I'm not that into it anymore kind of thing. And then agolia. So this is a reduction of speech, or so you're just speaking less, or you're not saying as many words as one used to say. And then affect. So affect is the outwards expression of a patient. So you have 5 different types of affects. So flat affect is just a blank expression. You're not going to see anything on their face, just completely blank, like you're not going to be able to tell their emotion. Blunted is kind of like minimal. You might know that they're angry. You might know that they're sad. You might know that they're happy. You wouldn't be so sure because they're not expressing it as much as they should. So that's blunted. Constricted means reduced in range or intensity. So it's one mood or the other mood, okay? So either you're super sad or you're super angry. It's one or the other. Inappropriate affect is incongruent with the actual emotional stage or situation. So what you should be feeling is not expressed. So if you start laughing when someone dies, like um, a normal human being does not laugh when someone dies, and if you do, I'm sorry. So kind of like they just don't match up. Yeah, of course you can go. Did you sign in at least? Just make sure you sign in. And if you didn't sign in, I'm gonna put awesome Anna. Okay, you can go for it. If you haven't signed in, just wait till the end and then I'll post it up again, the little QR code. So inappropriate is like they're not matching up. one to the other, they don't make sense. So that's inappropriate. And then bizarre, odd, illogical, inappropriate, unfounded, includes grimacing. It's just weird. Those are like kind of like your Joker, like that one face from The Purge. Just seeing that, it's just bizarre affect. Like it just doesn't make sense. You don't know why they're doing it. It's just bizarre. So those are your three types of affects: flat, blunted, constricted, inappropriate, and bizarre. Those are what you're gonna see. And then you have your normal ones that you see with regular humans. But those are the ones that you're gonna see specifically in schizophrenic patients. You always want to make sure that you assess each patient for depression, no matter what they have, because they can be at risk for suicide, and you never did the assessment on them. Okay, so always make sure that you do that. Here's a question. So Eric becomes anxious and says, "There are worms under my skin eating the hair follicles." How would you classify this assessment finding? Is it A, a positive symptom, a B, negative symptom, C, cognitive symptom, or D, depressive symptom? Keith says positive, Mary Beth says positive. I need one more at least. Okay, cool. So yes, this is a positive symptom. What type of positive symptom? We went over many. So what type of positive symptom would this be? He's saying there are worms under my skin eating the hair follicles.
Hallucinations?
It's a hallucination. It's not a delusion. So delusions. So have you heard of the word delusions of grandeur? So JK. So delusions of it's kind of like so hallucination are more dealing with the senses, as delusions are dealing with things at a greater scale, like believing that you're God. That's a delusion. While hallucinations have to do with the five senses and the command hallucinations. So out of the five senses, he's saying that he feels worms under his skin eating the hair follicles. So you told me it was a positive symptom. You told me it was a hallucination. So what type of hallucination is it?
Touch.
Touch. But what's the medical or the
Tactic?
tactile? Very good. Yes, tactile hallucination. So yes.
Sophia, I have a question about the delusion. Would delusion be if the FBI is or you pretended is that a delusion?
You're gonna see a lot that like, oh my god, like the FBI is like watching me through my phone because I was talking about Panda Express and I have the Panda Express app on my phone. Like that's another type of delusion that you're gonna see. But in this, I think I have seen it once on a practice question. I think that there was a delusion that that the FBI was trying to get at them, but you're gonna also see like, I believe that I'm a superhero, I believe that I'm a god, or I believe that I'm the president of the United States, or I believe that, what was the other one? I believe that I'm a professor or I'm a doctor. Like they 100%, like you can tell them that they're not, but they believe it no matter what, and that's what they're going for. So that's a delusion. Delusions are like at bigger things, while hallucinations tend to be more sense based. So just know positive symptoms. It's kind of like a little chart that I have here. So positive symptoms, they're adding on addition. So something that's not usually there to like the normal patient. So you have the hallucinations, delusions, paranoia, disorganized or bizarre thought, behavior, speech. And the positive symptoms usually happen because there's an excess dopamine in the limbic system. So in little words, that means there's just too much dopamine in the brain. And there is medications for that to help regulate all that dopamine, which is what we're going to learn later on. Negative.
So the positive symptoms happen because what? I'm sorry, because too much dopamine in the limbic system?
It says too much dopamine in the limbic system, but it's just too much dopamine in the brain, technically. Limbic system tends to get people confused. So I just say know it as brain. There's too much dopamine in the brain. And there's medications to help that. So medications tend to work better on positive symptoms than negative symptoms, which is nice. So then you have your absence, your negative symptoms, which is your absence, so you're taking away of something that's usually there for a regular human being. So anhedonia, remember that's interest. I'm sorry, interest or what's that? I'm trying to look this specific word. Pleasure. So that's the inability or the absence of pleasure in a patient's life. Avolition, loss of motivation, algolia, and then apathy. And the negative symptoms are a little bit more difficult to treat compared to positive symptoms. Okay,
So,
so
Sophie, what's lacking in negative in the brain? If dopamine
we don't
is
know.
la-
So
oh,
that's
okay.
what happens in patients that have schizophrenia. We were able to, researchers were able to note it down like, oh, okay, so what's happening, what's specifically occurring in patients with schizophrenia for them to have these positive symptoms, and they ended up finding that the dopamine 2 receptors were being attacked, releasing a surplus amount of dopamine in the system. But compared to negative symptoms, we still don't know what causes negative symptoms. It's kind of a weird reason, but we don't know yet why certain things happen with
Okay.
it. Yeah, good questions, guys. Good questions. So biopsychological interventions. So you have your antipsychotic meds. These meds are not the best. There's certain categories and to the medications, and as always, as nurses, we always try to do least invasive to most invasive, non-pharmacological before pharmacological. But because we are specifically dealing with schizophrenic patients, we tend to be, our first line tends to be medications before we get to the non-pharmacological therapies. But in theory, we want to do non-pharmacological first, okay? So we have our first generation antipsychotics and our second generation. So you would think first generation, oh, like we want to do those first. No, those are our last resort no matter what, because of the terrible side effects that they cause. And then we have our second generation antipsychotics. So those are your first choice. So kind of like when you bake a cake for the first time, like the first time it just comes out terrible. And then your second time around, it comes out better. Think of it like that specifically with these medications. Your first generation is just like, they're there, but they're there because like there's patients that have been on those forever and that's the only thing that works for them, no matter the side effects. And then the second generation are the ones that you're going to see more commonly in patients with schizophrenia. So we're going to talk about first generation antipsychotics. So remember how in positive symptoms we were talking about how that the dopamine 2 receptors were being attacked, hence why there's so much dopamine in the brain causing the positive symptoms. Well, first generation antipsychotics cause that dopamine level to go down, hence being better on the positive symptoms. So they target the positive symptoms, and these first generation antipsychotics are dopamine antagonists. Remember, guys, I'm going to be talking to you guys in generic name and generic name only. So I would appreciate it if we start to habit that just talking in generic name here, okay? No brand name. You'll thank me later for that brand name thing.
Okay, wait, Sophie, before we move on. So the antipsychotic drugs, the first generations, are the conventional typical of standard antipsychotics. So we're gonna choose always the first generation, but you just said that the second one is the best one.
Correct. The second one, so like back then they made these medications, I think in the 70s, when schizophrenia was still kind of looked like as like a godsend, like you were punished. So they tried to do their best with the medications and they kind of failed. So that's why they call it, it's kind of confusing because it's like the first generation. So why wouldn't you choose it first? The first generation, at least in these medications themselves, are just terrible. You don't want to try them at all. because of the fact that because it was their first mixture medications, they didn't really know the chemical compounds and how would they combine and place them on patients. So they ended all these chemical compounds that they were doing with the dopamine ended up causing worse side effects than with the side effects that they were trying to treat in the beginning. So that's why we kind of put them as the last resort. We don't, if you have a new patient in a mental health facility and they end up being diagnosed with schizophrenia, you don't want to give them haloperidol. You might kind of try to bring it down to like anything that's not that. And there's only a couple. There's like 3 or 4 that you guys have to know, which is nice. And they all kind of do around the same thing for the first generation antipsychotics, but just know second generation antipsychotics are first line therapy, not first generation antipsychotics. When the second ones came out, then they're just like, whoop, booting it out, because the fact that those side effects that first generation antipsychotics can give to a patient can kill them. That's the last thing you want to do is kill your patient. So that's why we have those. We have those there. Third generations, they're still kind of new. So we kind of still place them under like the second generation antipsychotics. You're going to see them on test as second generation antipsychotics. But they're third generation, you're going to see second generation more often, okay? When it comes to these types of patients. And trust me, I'm telling you guys this for a reason. So thank me later when you guys see that later. Not trying to say anything, but you know, it's just good to know. It's just good to know. So they target the positive symptoms because of the fact that first generation antipsychotics work on the dopamine receptors. But there's a bunch of disadvantages that may happen. So you have your extrapyramidal side effects. That's one. Those are your EPSs that you guys have to know. Please know these like the back of your hand. If I quiz you on these next week on these EPSs, know what they are, okay? These are really, really big, and know that they happen with first generation antipsychotics. Anticholinergic side effects, those make you sleepy. Those are bunch, dry mouth, all this and that, like, and then there's certain nursing interventions. You have tardive dyskinesia, which kind of falls into like an EPS, but not really. And then you have your weight gain, your sexual dysfunction, and endocrine disturbances. So this is patients go fat. They're gonna gain a lot of weight because of those metabolic disturbances. So first generation antipsychotics, I have 4 here. I think Tan's med sheet has 5. With Tan, know that med sheet, okay? That's my biggest, from what I heard. And I had friends that had Tan. I might have had Tan. I don't know if I had Tan. But those 4, you're gonna see them on upcoming quizzes, on your NCLEX, on the proctor. You're gonna see medications as they are. So just know them by the generic name. You have your haloperidol, your thiothoraxine, thiothorazine, and then chlorprozamine. Okay, those are your 4 first generation antipsychotics you guys have to know. Okay, so haloperidol can be used as an injection if you guys want to know. I got it, don't worry. So thiothiaxine, okay, those are, they might have been spelled completely wrong, but they look like that, okay? Those are your 4 known first generation antipsychotics. And there's a lot to know about these, okay? So first generation antipsychotics cause EPS, which are your extrapyramidal side effects, okay? So this is an umbrella term for what all the EPSs are, because there's 4 or 5 of them. There's a bunch. So you have movement disorders. So EPS, and then you got, for under 1, you got movement disorders, and there's different types of movement disorders. You have dyskinesia, which is the abnormality abnormality of voluntary movement. So you have, under dyskinesia, you have tartative dyskinesia. So this is usually late developing. So you're going to see this happening over time, happens over a long time of a patient who's been taking a first generation antipsychotic over a long time. Okay, so this is not rapid. Happens gradually. Um, so they're abnormal movements. So you're going to see tongue thrusting, lip smacking, facial grimacing, eye movements, and repetitive involuntary movements. So any medication that blocks that dopamine receptor, because there's that dopamine receptor has been messed with, and it's just releasing so much dopamine, hence causing these positive side effects. These medications block that to stop that release of dopamine. So because you're blocking that dopamine, these side effects happen. So just know tardive dyskinesia, it looks so silly. You're like blinking your eyes, your lips smacking, your hip thrusting. Those are the three that you're going to see the most. And they're just abnormal movements. So tardive dyskinesia is cured with an antihistamine, such as Benadryl, okay? Then you have the AIMS. So the AIMS scale is something that when you have a patient with tardive dyskinesia, this is kind of like a grading scale based on how severe the movements are. Okay, you're not going to see a lot of questions like those, but it's nice to know that the AIMS scale is what is used to classify how rigorous or how intense those movements are. And then you have acute dystonia, and that needs urgent and medical intervention. And I think they have to be sent to the ICU as soon as possible. So this is this is rapid, can happen between 5 to 15 minutes, and it needs urgent medical intervention. So that's why you see in some of the medications, if you look into them, you have to stay with the patient for at least 15 minutes to see, or like go check up on your patient in 10 to 15 minutes to see of any like side effects that may have happened. So here's a scenario. So let's say you give your patient haloperidol, okay? And then you go do your run at another patient and you come back. And then your patient's neck just has torticollitis. So they're just right there to one side and you can't really move them. And it's kind of like a muscle contraction and it just stays there. Once you see that, you should be calling already. Like, oh my God, my patient has acute dystonia and this needs to get cured ASAP. It's cured with a diphenhydramine injection. So that's why when patients, it's already known if you're going to give a patient a first generation antipsychotic, it's smart to give them an injection of diphenhydramine added to that to prevent dyskinesia or acute dystonia more needed. The contraction has to be treated with the anticholinergic or an antihistamine, and that's when the acetylcholine receptors need to be blocked as well by the antihistamine. Another big thing that you're going to see in the EPS, remember, we're still in EPS, okay? We just went over all the voluntary movement disorders, which are your dyskinesia and your acute dystonia. Now we're going to go under the other term, which is your akathisia. So please don't get the akathisia and then a dyskinesia confused. They're two different things. So dyskinesia.
Okay, Sophie, sorry. Okay, so for the EPS, we have two major ones that we have to look for, right? Acute.
No, we're still going over EPS.
Oh, okay.
So there's EPS, there's movement disorders, and we just finished talking about movement disorders. We still need other ones that fall under EPS. Okay, so there's a bunch that you have to know for EPS, and know that this is a side effect that happens with first generation antipsychotics. This is why we don't give first generation antipsychotics, because we're trying to prevent these side effects because they can be long lasting. And then, so we just finished movement disorder, EPS, movement disorders. We're done with that. Acute dystonia and then dyskinesia were under movement disorders. Now we're going to go into akathisia. So akathisia is a reason EPS is only for first gen, correct? Yes. So akathisia is another type of is another type of a term that's used. It's a big reason why people stop taking the medication. So if you put them on take outpatient on antipsychotic medications, they're gonna stop taking the medication because of this one specifically that we found. So that's akathisia. So it's internal restlessness. So this is feeling like you are just full of energy and you just cannot find time to rest. Imagine feeling that way, that you just can't sleep, you can't nap, you're just full of energy all the time. That's exhausting. So they can, you can see them pacing around, but it's more like they'll be sitting down and just like, why can't I fall asleep, why can't I do this, why can't I do that? It's more internal. You won't really see it externally, but that doesn't mean that it's not impossible. Okay. So it's usually found early in treatment, but it can persist and it can become permanent. And to cure akathisia or to treat akathisia, you want to give congentin or propranolol. Okay, the beta blockers used. It's so weird. I'm not sure why a beta blocker is used, but that's used for akathisia. Okay, congentin and propranolol are used to treat akathisia. All right, so we got our movement disorders, we got our akathisia, and now we got our Parkinsonism, or pseudo. We can also see it as pseudo Parkinsonism. Did anyone say something?
Sorry, I have a question. So with akathisia, like what, other than like the internal restlessness, what kind of like physiological things that are things that we could like look for?
Physiological.
Like would they have like, I don't know, high blood pressure, or they'd have insomnia, stuff like that?
Let me get back.
Yeah.
I'm looking at it because I haven't been asked that. I don't ever think I saw like like vitals, but I can look into it. Yeah. I mean, you would get orthostatic hypotension, but that would be because of the anticholinergic effects, not specifically akathisia itself. I don't think akathisia would be more like a subjective finding that you would find on a patient, like, oh, they feel like I just can't nap, I feel like I'm full of energy and I can't rest. So you're kind of taking their word for it, even though you can't see it and there's no vital signs that can say, no lab test that can tell you. You would take it as like, okay, they're doing this, that's a sign of an APS. Let me see. Yeah, if anything, the most you're gonna see is like that dry mouth, the tremors because of the Parkinsonium. Those are physical ones, but specifically with akathisia, I don't ever remember reading in the book or anything about specific vital signs that you'll find. Only with the only vital sign you'll really specifically see with is that's with the anticholinergic effects. Okay, so hopefully that helps.
Thank you.
So Parkinsonian, so late onset. So you have like, they look like Parkinson patients, but they're not, because they haven't gone to that point of mental degradation. So you have cognitive degradation. So you have your pill rolling effect. So they're constantly going like this, cogwheel movement, shuffling, and a mask-like effect. Okay. So this happens like over time. You're gonna see this with these patients. So medications to treat extrapyramidal side effects. So those were your extrapyramidal side effects. Okay, that's a big umbrella term. So your movement disorders of acute dystonia and your dyskinesia, you have your akathisia, and you have your Parkinsonism or your pseudo-Parkinsonism. Those are the three that you're gonna see. So medications to treat EPS. So you have your benztropine, and then you have your diphenhydramine. So benztropine is an anticholinergic. So those treat you like your big major side effects. So your constipation, urinary retention, sedation, and blurred vision. So also known as brain dulling. So those are the anticholinergic effects that we're going to talk about later. But benztropine is really, really good for that. And then diphenhydramine, Benadryl. So just like Benadryl is kind of to relieve the histamine receptors in the brain. Diphenhydramine is used as an antihistamine. So that also is used for constipation, urinary retention, sedation, and blurred vision, and propranolol. So so remember how I mentioned how propranolol can be used to treat akathisia, which is your internal restlessness. So propranolol is also used for the tremors that you might see in pseudoparkinsonism and as well as akathisia. Another big thing that you're going to see in first generation antipsychotics is your NMS, so your neuromalignant syndrome. So this is also due to any medication that blocks that dopamine transition. Like, see all these side effects that are happening because of one medication. That's one of the reasons why we don't like using them, because we don't want all these side effects to be happening. So neuromalignant syndrome is a medical emergency. So you're going to see a high fever, altered mental status, confusion, muscle rigidity, and then autonomic instability. So this means that your vitals are going to be going up and down like crazy. Okay, you're not going to have any vital baselines, or they're not going to be stable. This is not an extrapyramidal side effect. Okay, this is by itself. You have to send them to the ICU immediately, okay? This is a major medical intervention. The first thing you want to do as a nurse is stop all antipsychotics. That's the reason why they're having this, okay? The first generation antipsychotics cause the neuromalignant syndrome, okay? And then you want to do supportive care, okay? They're having hyperthermia. What do? You do cooling measures. They're losing all this fluids because of the fact that they're having diaphoresis. Why? Because they have high blood pressure. So you want to give them fluid replacements, place them on some saline, you know. And then what's really good for this is benzodiazepines, dantrolene, and then amantadine. Those are your 3 medications that to cure neuroleptic malignant syndrome for the time being before you send them to the ICU for critical care. So it happens quickly. No one really knows why no one really knows why NMS is caused. It can be from the start of medication. It can be because you stop the medication, or it can be because you increase or decrease the medications. There's so much that happens that we're not really sure why this occurs, and this can also cause death. Okay, your vitals are going up and going down. They're going up and going down. You got to think the patient is crashing at that point. No, he's not stable. So this can cause death. And now we're on to our second generation antipsychotics. So this is our nice ones. So that's later on. So these are second generation antipsychotics. So the difference between these is that this one combines serotonin and dopamine. So this is nice because it treats both positive and negative symptoms, okay? So it has little to minimal EPS or tardive dyskinesia, which is nice. But the only disadvantage to this one is that it does cause metabolic syndrome, which is just weight gain, okay? So you had dyslipidemia. So you have like irregular fat levels in the body, increased blood glucose, and insulin resistant. So these patients can become diabetic, okay? You're messing with the sugar, you're messing with the insulin, both things that both affect the liver. It can cause diabetes. So increased blood glucose, the cells get fed up with so much blood, but there's no insulin to try to check that. So you tend to cause diabetes type 2. Okay, so your second generation antipsychotics, also known as your atypical antipsychotics. So you have your clozapine, which is very common But it's the most single effective antipsychotic. So this means they can just give them one antipsychotic and they're fine. And just this one. Sometimes you have to do a whole cocktail. And that's something that we're trying to stay away from. We're trying to just give them one medication only to try to help them. So clozapine, second generation antipsychotic, I'm sorry. But with clozapine, please note this down. This is very, 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 very important. Clozapine, you have to monitor their ANC. So this is their absolute neutrophil count, okay? Because this can deplete their neutrophils, otherwise known as your red blood cells, which can put the patient into risk for infection, okay? So it can cause severe neutropenia, also known as agranulocytosis. So before you give the medication, you want to monitor their ANC. Their ANC is number one. You want to check that one. But if you can't get their ANC, you got to check their white blood cells. But you want to check their ANC for optimal. Optimal check is their ANC. I don't remember. Yeah, ANC, absolute neutrophil count. That's your number one. Sometimes some professors that I know might just say WBC, but I think if I'm right on ATI, it says ANC, so you want to go with ATI. And if your patient, if your professor says it gives you all these and it doesn't say ANC, choose WBC, okay? And if they give you ANC and WBC in their question as to what should you check before you administer clozapine, we're gonna get questions like that. So easy. You want to check ANC, if not WBC. But if they tell you that ANC is wrong, fight with them on the ATI book that it says ANC is right, okay? Don't ask me, but I know. Don't ask me, but I just from personal experience, okay? So severe agranulocytosis, kind of think chemotherapy patients. Chemotherapy does affect their granulocytes. So it brings them down and makes them immunocompromised, so at risk for infections, just like this medication brings that white blood cell down, makes them immunocompromised, risk for infection, okay? So you kind of want to teach the patient how to monitor for signs of infection, okay? If you're feeling sweaty, if you feel like your temperature has been going up, if you notice a runny nose, okay, maybe a cut that hasn't healed, those are signs of infection, okay? Or a cut that has pus coming out of it, signs of infection. The smallest thing that they get because their neutrophils are so low can put them at risk for sepsis as well, okay? So you want to monitor for change in vital signs, if they're febrile, so if they have a fever, or tachycardia, so high heart rate, and then you always want to get their vitals, and you want to monitor for a sore throat or a thrush, which can lead to or be a precursor to infection. It's going to cause weight gain. Second generation antipsychotics are so known for their weight gain. And then monitor the absolute neutrophil count, which is a calculation based on the WBC. If it's below 1,000, or I think it was below 1,500 or 1,000. If anything, it's going to be a super duper obvious number, like 5, or like 30. That's how you know that they have an infection, okay? They're not going to give you anything close like 900. They're going to give you something real far off, okay? So anything below, I would say 1,000 to 1,500, infection. Because I think it has to be in between 5 to 10,000. I think, I can be wrong. Don't quote me on that. So before administering clozapine, you want to check for the
all of this information is still for the chlorazepine, right?
This is just clozapine, yeah.
Okay, thank you.
So before administering clozapine, you always want to check if their ANC has been drawn first. If not, you want to call the doctor and get an order in to draw their ANC. Best nursing practice, of course. So second generation antipsychotics, more of them, you got your quetiapine, olanzapine, and risperidone. They cause the most weight gain, those three. And quetiapine, olanzapine, and risperidone are the ones that you're going to see most commonly. Risperidone can cause hyperprolactemia, okay? So this is an increase in prolactin levels. So in men, this can cause gynecomastia, which is man titties, because of the imbalance in their hormones. And then in females, so this is risperidone, which is another second generation antipsychotic, and specifically to risperidone can cause hormone imbalance known as hyperprolactinemia, which is like an imbalance in their hormones, which can cause gynecomastia in males, so otherwise known as man titties, and then galactorrhea in females, which is an increased production of milk, like breast milk, and then amenorrhea, which is a lack of your period. So that's what risperidone can happen. All these are happening because they're dealing with your hormones, okay? So that's risperidone. So ziprasidone, so that's just you take it with meals, and then you got to monitor for dysrhythmias, okay? Because it can cause abnormal heart rhythms. And then you have your paliperidone, your enalaprone, and then your asenapine. I have seen asenapine a couple times. They're less common, but they're ones that you need to know, that I feel like you should want to know. Because I mean, I've seen asenapine, you know, and asenapine's like super duper not as common as you would see like olanzapine or even clozapine, even though all those side effects can happen in risperidone. Sorry guys, give me a second. It's so hot. This weekend's gonna be like 100 and something degrees. I'm not ready for that. Okay, so caprizine? No, asenapine. Paliperidone, enalaprine, or are you talking about ziprasidone or asenapine? I've seen asenapine a couple times, even though it's so rare. I mean, it's just good to know all the words. Antipsychotics, these are your third generation antipsychotics, but they're really a subset. So kind of like you got your second generation antipsychotics part 1, and then like your third generations, which is like your part 2, you know. So they're not going to be considered third generation, even though they are, but because they're going to be under that subset of second generation antipsychotics, okay? You have your apiprazole, luacidone, which is brand new. You're gonna see that. You're gonna see Latuda most likely. You're not gonna see lorazepam, but I've never seen a question with Latuda. Okay, your brexpiprazole and your cariprazamine. I don't know. Those are just like your second generation antipsychotics part 2. You know, the ones that are brand new and there hasn't been much research to be done on them. All we really know is that they improve positive and negative symptoms and cognitive function. So these kind of help on that, those alterations in speech, okay? And then there's less of a risk of extrapyramidal side effects and tardive dyskinesia, but they're always still a risk, okay? But you're most gonna see them with that first generation antipsychotics. Like if you were giving them a second generation antipsychotic, even a third generation antipsychotic, it would be like a 3 to 5% chance that they have them, compared to if you were giving a patient a first generation antipsychotic, it'd be like a good 70 to 80% chance that they would have the EPS or tardive dyskinesia, okay? So that's a nice thing about having that second generation antipsychotic. So why are new ones preferred than the older ones? So that metabolic side effect, okay, yes. I would honestly rather gain some weight compared to like having internal restlessness. Personally, I don't know about you, but I don't mind getting a little thick compared to having all the crazy side effects that they get. And there's a way better improvement on the symptoms and the side effects, okay? Let me see. And then you got your cultural implications. I feel like that was very, very covered in funds. You know, culture is very big in in medicine and nursing specifically, and you don't want to generalize culture and be like, oh, because you're Mexican and you believe this culture, that Mexican believes the same thing and does the same thing that you does. No, very, very big. So you always want to ask them and make your patient feel comfortable. Don't do any remarks that make your patient feel uncomfortable. You always want to be a culturally competent nurse, and that means having cultural awareness, which is examine beliefs and practices of their own culture, and that's the patient's culture and the nurse's culture. And as a nurse, you want to, even if their culture does something that you don't agree with, you want to put that boundary in and not let it affect you, because at the end of the day, we're here for our patients, no matter what they think and no matter what religion they believe in, no matter what culture they go for. Okay. Okay. Is there anything else you guys want to know? Oh, that's one thing I want to tell you guys. So what helped me a lot in mental health to know the meds, I know those were just a couple meds that already seemed like a lot. The more you go, the more I promise you, if you do this, by the time the proctor comes and you know those meds, because there's two different types of proctors, I'm letting you know now, there's two sets, okay? My proctor wasn't that heavy on meds. Thank God it wasn't that heavy on meds, but I do know my friend's proctor was heavy on meds, okay? So that you don't know what proctor you're gonna get, and the proctor you get is gonna be the same. It's gonna be the complete different than the person's proctor next to you. And I promise you, no matter what you do, it's not enough studying for the proctor. Okay, I'm letting you know that right now, because I was just like, I read that entire book, and I was like, I got there, and I was like, you know what, I'm gonna kill it. And then the first question, I was like, you're kidding me, right? Let me get it for you guys. And I want you guys to see this. And yes, they're not easy. They take a very long time to make, but that's how it is. Yeah. So they take a very long time to make, okay? But I promise you that you will thank me later for this. Did I give them away? No, I don't think I gave them. Here we go. Antipsychotics. Cool. What I suggest is, we all have a farm book, right? I'm pretty sure we never touched it, okay? I get it. I never touched my farm book until I got to this. Was it this? No, I never touched my ATI farm book until I got to intermediate, okay? That farm book will save your life, okay? I promise you, you might think I'm a crazy girl for going off on the meds, but I promise you, you will thank me later, and I've been thanked before, okay? So something's working. Who did this? No. Oh my God, what happened? Oh my God, I'm not sure. You guys saw that, right, too? You guys saw that, right? Please don't tell me oh my God, I did that again. What is happening? Oh my God. It just keeps like, I'm sorry, was it just me, or did it happen to you guys too? No.
What?
There's I guess there's another PALS meeting happening. I don't know. See, it just keeps saying that I'm signed out of my account because there's another account signed in on this device. I think it's just me. Yeah, crazy, huh? That's on the mental health tutor. Just kidding. Mental health's awesome. But yeah, I guess someone's trying to log in. I wonder who it is. I don't think there was anyone after 8. That's crazy. I don't know. You got 30. Okay. So that ATI book, the pharmacology one, it's like this thick. But I promise you, if you do this starting from right now, I promise you, you'll thank me later, okay? You'll thank me when it comes to that proctored for farm, for your upcoming medications, and from now on. I mean, I haven't used it right now in OB, but I used it like it was practically, I had the MedSurge ATI book, the fat one, and then I had the other fat one, the farm book, back and back in my bags, going to go study at my friend's house. Because you will not understand the meds if you don't have that farm book. And yes, it's a cute chapter in the medication in the ATI book, but I promise you that farm book has way more information that the ATI proctor will throw at you. So this is what I saw in my farm book. So I'm going to show you this one, and I did this for every single one of my meds. Even in intermediate med surg, I did these. So I have the title of the medications. So I have antipsychotics here. I would classify them as, I can't believe you guys can't see it. My lighting. Okay, I'm going to see if this helps. Let's see if this helps. Does that help? I think a little bit better. Or so I don't know if you can see. So you have your drug class. I would separate it, and it literally gives you in the ATI book, like it says drug class, and then expected pharmacological reaction, and then therapeutic uses, and then it would go like complications, contraindications, which is really nice how it sets it up. So it took me, maybe took me 3 hours to do, but I promise you, it's 3 hours I don't have to study later on, okay, when I'm tired and exhausted with nursing school. So I have the drug, I would separate them in drug class, names, and I would, this is your prototype medication, and then I would have here, what's this one? Your therapeutic uses, your complications, and then your contraindications. And that's how I would separate each one, and I would type it out, and I promise you typing it out or writing it down, however you feel like it will make it stick in your brain. So under the drug class specifically, I would have what it is, and the method of action, and how it treats it. So the therapeutic uses. So first generation antipsychotics, what their method of action is, they bind to those dopamine, norepinephrine, and more. So that's what it teaches you in the farm book, okay, compared to the compared to the mental health book. And then it treats positive symptoms. While down here, I have my second generation and third generation antipsychotics, and those treat positive and negative symptoms, the method of action, and then what each are. And that's how I would do it, okay? And I promise you, if you get that farm book, if you do these, set up 3 hours a week to do these on the medications for that week, I promise you, and you do them, please put that generic name, thank me later. You put that generic name in here and you will memorize it, okay? And yes, it will help you, because they're usually like nausea and vomiting. I can't believe how many medications I've seen with nausea and vomiting, okay? That will repeat and repeat and repeat. But EPS, I haven't seen that with many medications. But doing that, I do know that EPS is caused by first generation antipsychotics. Metabolic syndrome caused by second generation antipsychotics. And I'm not even looking at that. That's just by memory. Okay? So
oh, it's this one, right? Hold on, turn my camera on. This one? Oh, the other one? Okay.
I can get it for you guys. Give me 1 second. It's this one, this fat one. This one, it has literally like, can you see how much I used it? How like messed up this is? Poor thing. I feel like I should have just done this way earlier back in my nursing school career, because it would have helped me so much. And this is what people don't tell you, because people don't like people in Mescos and just whatever. So yeah, so Unit 2 is everything affecting the nervous system. And it has all the different types of medications. You got your depressive, you got your anxiety and trauma, bipolar, psychotic, children with adolescence, substance use, and then you got your other ones, which are something like your disorders. You won't need to know that until you get to med-surg. Chronic neurological disorders, I think you might just have delirium on there. Just to focus on delirium. Parkinsonism, you don't have to focus on that. Another one too, Parkinsonism. What's that other one? It's like combined with Parkinsonism that old people get. Dementia. I think I learned about dementia there in mental health later on. yeah, so I would go by this one and then just use this. Repeats with the mental health farm section, but if I were you, do this, make it into this, and thank me later, because I promise you that's something people don't tell you, but that's something that saved my life. And it saved my life in intermediate med surg, and I was going to be the intermediate med surg this term, but I'm in OB for a reason. And I'll do it. Hopefully I'll be able to do it next time for you guys. And yeah. You guys got 30 minutes to ask any other questions, anything. Ask me anything about the class, ask me about the proctor, ask me about any supplementary resources, ask me about this. You know, you guys got 30 minutes, so please ask. Of course, of course. You don't get these tips unless you come, okay? Any other questions? Therapeutic communication. I'm pretty sure we've learned about therapeutic communication. I'm pretty sure. Are you guys good with therapeutic communication? I hope you guys are. You wouldn't be here if you weren't. Let's be honest. Therapeutic communication was fun. So paraphrasing, restating, and exploring, open-ended questions, closed-ended questions, the miracle question. That, of course. Did you sign in? Make sure you sign in, guys. Okay. Let me put that up for you. Yeah, I'm gonna share the screen. Just scan that. You know, overt and covert. Overt's like obvious, and covert can be like hidden, so you don't really know what their end goal is. Overt, covert. Haven't really seen any big questions on overt, covert, but I mean it's good to know for therapeutic communication. Restraints.
I have a quick question, Sophia. Okay, so for the when you're talking to a patient, I know that you need to be sitting down, but you're at eye level, right? Like you're at eye level. You're not sitting on the side, but you're at eye level with the patient, right?
Correct. So like, yeah, you can like maybe move down their bed, pull up a chair to the side, and like have them like make eye contact with them, or depending on their culture. I know that in Asian cultures, like looking down is a sign of respect, which is something that was taught, I think, yeah, in this term. The different types of cultures. Some people do eye contact and like making sure that some cultures respect eye contact as a sign. I use that as a sign of respect. What else?
Talking about cultures, do you happen to know which one involves the client's family to assist with activities of daily living?
A culture.
If you know. Because I thought it was Asian, but then my friend was saying, no, it's Latin. And then, so I wasn't sure because Latin, then I saw a question on Success Book and says that a Latin man who needed help bathing and comes in a female, nurse to bathe him. And he was like, no, you can bathe me. And although we're very touchy, like we're okay with touch, but that part was not okay.
So that, as I'm pretty sure you're Latin as well. I'm not assuming, but I pretty sure from what you mentioned, I hope I think that you're Latin as well. We have a big thing in our culture called machismoism. Have you heard of it?
Yes.
Because in our culture, I don't know if you guys know this, but in our culture, like men are trying to be like the big honcho ones, which is like totally bad, totally unhealthy. I'm gonna stop share, okay? So in that case, it's more of like the machismoism coming in and just being like, oh, like I can do this by myself. I know I'm sick, but I can still do it by myself because I'm a man. I think that was part of the explanation compared to that in the culture sense. but yeah, that was the question about yes, we are, but in that case, he said no because it put him in a more vulnerable state, and he just didn't want the help because of the fact that he is a Latin man, and we know how those Latin men are. Yeah, I have a dad. I think specifically with the specific culture, I feel like at some point, I don't even think it's culture at that point. I think it's just family, you know? Like, if your loved one is sick, of course you're going to want to go help them with their activities of daily living as family. You know, you wouldn't want someone else, even though it's their job to. I don't think you would want someone else to help your family member with their activities of daily living, even though it's their job. So I think that's just more family than it is culture, because that's very, very wide respect, you know? Like, I don't think there's just, oh, I'm white, so, nor I'm not even, that's white's a race. I'm Indian and we don't help our sick, you know? Not saying that they do, I don't know. I'm not one to speak, but I was just hypothetical, okay? So yeah, so I think it's just based more on like the family themselves than culture when it comes to that. Trying to see if there's anything else I can help you guys with. Miracle question is like more looking into the future. So like, what can you see yourself doing in so many years, or like, what would life look like if you didn't have blank and blank? Miracle question is very good in all mental health, but miracle question is also very, very good in addiction. Okay, what would life look like if you weren't addicted to blank and blank? Okay. Clozapine, monitor ANC. Risperidone, look out for prolactin levels, monitor for prolactin levels.
Wait,
TB.
Sophie, I'm sorry, I didn't get that. So for the magical question, you said that it, huh?
Miracle question.
For the miracle, okay, I'm sorry, I keep getting those mixed up. I'm so sorry. Okay, so those are good for alcoholics.
They're good for
alcohol.
you're gonna love them in general. That's something, if you're looking into mental health, you want to use the miracle question because it has the patient think into the future. Okay, you can use the miracle question in any. It doesn't have to be just for schizophrenics. It doesn't just have to be for patients with addiction in general, but it can be very, very useful in that case, because you know, addiction, what you're going to learn later on is that patients with addiction can't really find themselves an outlet, hence why they tend to always resort back. So when you are assessing a patient, you want to throw in that miracle question, like, oh, so like, how would your life look like, or how would you think your life would look like if this wasn't involved? You know, it has them thinking like, oh, like, getting into like a second portion of their life. Yeah, thought process, speech patterns. So remember, speech patterns are manifestations of disturbed thought processes. Echolalia, clang associations. If you see those, just know that something is happening in their thought process that's being altered or disturbed. Okay. Metabolic side effects: weight gain, increased blood glucose, dyslipidemia. There's more blood sugar. The cells can't take it. The insulin starts to become resistant, so it can cause type 2 diabetes. Okay, but I'd rather have diabetes than EPS. Okay, that's just me. I'd rather have diabetes than EPS if I were like a psychotic patient. Duration and symptoms required for diagnosis of schizophrenic disorder, psychotic disorders. Big thing. I had missed that 100%. Let me get you that answer. So yeah, so everything, you can't just walk into a doctor's office and be like, I have depression. Okay, you can't do that. You may be feeling depressed, but you can't say, I think I'm gonna diagnose myself with depression. There are certain, and I'm only using depression as an example. Okay, there are specific parameters you have to meet. So specifically with schizophrenia, you have to have 2 or more of the following significance in 1 month, and it has to go on for 6 months. Okay, so you have to have delusions, hallucinations, disorganized speech, gross disorganization, so like being majorly disorganized, catatonia, any type of negative symptom or functional impairment of some kind. So it has to be 2 or more of those, okay? Has to be in 1 month, and it has to follow on for at least 6 months. So it has to be constantly going on. So 2 or more of the list, they're usually delusions and hallucinations. They have to go on for most of the time during a 1 month period, and it has to continue for 6 months, okay? That's how you diagnose by the DSM-5 schizophrenia.
So I have a quick question about that, Sophie.
Uh-huh.
So if delusions is not present in schizophrenia, it's not considered schizophrenia. So like, let's say I have bizarre behavior and disorganized speech. Those are still 2 out of the category, but I don't have
So
hallucinations.
it has to be 2 or more. It's usually delusions or hallucinations. It's usually delusions or hallucinations, but it does not mean that they are always delusions or hallucinations. Those happen to be the ones that are the most common that you're gonna see. Of course,
Okay.
specific people, like a nurse cannot diagnose a patient with schizophrenia, but the doctor will make that determination. But it has to be under that criteria, you know. So schizoaffective disorder is a full-on, which is what you're going to learn later on. Schizoaffective is full-on schizophrenia with either a combination of bipolar or major depressive disorder. So schizoaffective is schizophrenia and bipolar, or schizophrenia and major depressive disorder, okay? You always want to rule out all medical explanations first. And then I know that you guys talked about the MSE, so the mental statics exam. So those have 5 different types of components, I would say. So you got your thought process, your thought content, your cognition, and your insight or judgment, okay? So the thought process has to do with the way that you think, not the speech, compared to alterations in speech, where in this case, alterations in speech are, remember, a disturbance or an alteration in your thought process that comes out in the way that you speak, okay? So the mental statics exam, all the mental statics exam is objective, so you're going to be able to see it as a examiner, but mood and thought content are subjective, so those you have to base on the patient's outward expression of it, so how they feel. Remember, subjective is how the subject is feeling, objective is what we're going to observe and see. What else? And yeah, schizophrenia affects 1% of all adults. They usually present in 15 to 25 years of age. It's child onset or late onset are more rare. Males sooner than females. So you're gonna see male onset way faster than female onset, okay? Any other questions? So schizophrenia is just schizophrenia in itself. So that's those the two in that list, that whole list that I gave you. It's the two or more out of that criteria. But in schizoaffective, that's whole schizophrenia and bipolar. Okay, like a combination of both. Or another type of schizoaffective is schizophrenia and major depressive disorder, another combo of both. That's the difference. So you have schizophrenia, which is the criteria, which is like your delusion, hallucination, your altered thought process. So that's schizophrenia, pure schizophrenia. Then you have schizoaffective, which is pure schizophrenia, and another added on mental disorders such as bipolar or major depressive disorder. Okay. So yeah. Yes, perfect. Great explanation. Love that. Yes, that's exactly what schizophrenia. That's literally what I have in my notes. It's like schizophrenia plus bipolar or schizophrenia plus MDD. All right. Okay. Is that it? Are we all good? Any last questions? I know it's late. I know maybe you guys have a quiz tomorrow. Oh no, it's Friday tomorrow. Oh no. Go relax. Go relax. Go relax tomorrow. All right. Any last questions?
I have a last question, Sophie. So for a patient that is coherent, or I should say patient comes in, we need to take a history. No, patient is not coherent and we need to take a history or whatever. So we can't get it from them, but we get it from a friend or a family member. However, we still need to get a release of records. But how do you get that if the patient is not there? You still ask him to sign it?
When a patient is not there and it's usually like known not to be there, when it's usually like an episode, we tend to let the episode pass and have them there because they're a danger. We can't just let them out, you know, they're a danger to society. So in that case, when we know that a patient isn't there, they usually have, which is something you're going to learn later on, they usually have like what's it called, kind of like a adult that's in charge of them. So anything that's medical has to be like a guardian, kind of like a guardian. IPS, is that what it's not in? Is it an IPS? LPS.
You're talking about CO's convener, like Britney Spears, like her dad is her.
Britney Spears, like Britney Spears, like Britney Spears, like Britney Spears. You know how like she's not there, so she has her dad, and her dad makes like the decisions for her and everything, kind of like that. If we know that, or if it's history that this patient is just going through this episode, we tend to let the episode pass and then we talk to the patient. But if it's known 100% that this is like them not being there 100% is known, then we go to like the person that's in charge of that, and that's usually the case. I feel like they do talk about it in mental health, but I don't. There's a specific name for it. That was that the first week that you guys learned that. No, it's like
Yeah, it was the first week.
Yeah, it was the first week. Man, I wish I can give you guys a complete.
Yeah, that's it. It's conservatorship.
Oh, yes. Conservativeship. Or like, if they don't have that, yeah. Like for administering medications and stuff. Yeah. Yeah. Like a Reese petition. That's what it's called. So like, a patient, like it's usually the family member that kind of takes over who they are. Conservativeship, yeah. That's learned in the first week. Yeah, that's what would happen. So if we know it's an episode, we tend to usually let it pass, have the patient safe in the hospital, and then talk to the patient. But if we know that this patient is not there 100% and that they have that person that's in charge, we tend to go to that person that's in charge. Because at that point, this patient is unable to take care of themselves, hence why they have that conservativeship there. And yeah. All right, guys. If we don't have any more questions, that would be it. I'll be here next week at 6 to 8. If you guys have any last minute questions, let me know. You guys can always contact me through my email. It's just you can literally like type into the WCU email, Sophia Santana. I'm the only one from West Coast that's called Sophia Santana. Just copy that there, and you're all good. Okay. If not, then I'll hope to see you guys next week, and I hope this helps, and let me know how your quiz goes, okay? Take a deep breath in and out, and you guys got this. Mental health is not impossible, because if I did it, you guys can do it too. I'm letting you guys know that now, and it's not a lie, okay? All right, guys. All right, see you guys next week. Bye. Have a great day. Thank you for coming. Bye.